very excited to welcome colleagues from 3 different countries who will be presenting case studies. We'll have a brief panel Q&A, and then we'll be using the last 2/3 of this session for hopefully some very exciting and interactive breakout discussions, and those will be facilitated for you at the end. And then we'll have a report out. So just to be sure that everyone is on the same page with some key terminology before we get started, I want to break down the difference between costing and budgeting. Often we talk about costing for WaSH and healthcare facilities, which we use to mean estimating how much a particular service will cost, so the expenses incurred for that service to deliver a good or service over a particular time frame. And we might think of the objectives of this as determining the costs to establish and maintain basic water service for 10 years. We can think about the next step to this is going beyond costing to actually start budgeting. And when we think about budgeting, it's not just how much it costs, but it's creating a plan for who will pay, how much they will pay, and when they will pay over the time frame of a good or service. So if we expand on our previous objective, we might determine how much each stakeholder will contribute every year over the water supply's lifespan to ensure sustainable service delivery. So if we compare these two concepts, we see that costing is the first step, but it doesn't actually get us to sustainable services. We need to know how much something costs, but then we also need to engage with these difficult questions about who will pay it, when will they pay it, and how will we divide up these responsibilities to actually reach sustainable service. So I'm sure this is not news to many of you in the audience, but just as a brief review of our global priorities, the WHO and UNICEF have laid out their 8 practical steps to reach universal access. And step 2 of these 8 practical steps includes developing nationally costed roadmaps. So the WHO and UNICEF has identified this as a high priority for reaching universal access. And we can also see, for those of you who may have gone to the Global Summit on WaSH and healthcare facilities in Amman, Jordan, just over the summer, budgeting and financing emerged as a key priority from that session as well. So this is very much on the global conscience for WaSH and healthcare facilities in terms of how do we move beyond where we are to actually make meaningful progress towards universal access. So what is the state of the evidence? So if we look at the work that's been published by, within the formal academic literature, as well as gray literature and reports that have been released by many of the wonderful organizations that are attending this conference, we see that there's growing evidence on the costs of achieving services where those costs have been documented and disseminated out, and there's raw dollar figures for the amount of money that it's going to take. We also see a variety of tools that have emerged to aid costing. I will say, for those, there's much more than the few screen captures that are here on this slide, but we have a pretty good emerging evidence base that's developing, and there's a lot of buzz around how much it costs and tools to collect those costs. But when we look at that evidence base, it hasn't necessarily always translated into action. Just because we know how much something costs doesn't mean that we necessarily have a plan to pay for it. And when we look at data that's collected, we see that fewer than 20% of countries currently reporting data have actually developed national coordination mechanisms and costed roadmaps to actually put a plan forth to achieve these costs that we've estimated. So to get to the theme for our session today, we're kind of at this stage where we have cost data and we're trying to get to these next stages. We're trying to have facility level budgets, to have strong regional planning and coordination around finance, and to work towards these nationally costed roadmaps. But we're not quite sure how to get there. And so very shortly, I will welcome up 3 presenters to highlight country case studies around some of the excellent work that they're doing around leveraging data for evidence, or leveraging evidence for policy and practice. And then we hope to have a robust discussion with those of you in the audience around how you're collecting evidence, how you're using evidence, and some of the barriers and successes and success stories that you have to share with us, so that the results of this workshop ultimately will be written up. For those, I'll plug as a UNC rep our collaboration with PLOS Water, PLOS Sustainability and Transformation. So we will be disseminating these findings out to the global audience. So please do stick with us to share your expertise. With that, I'll welcome up my presenters one at a time. First up, we have Carrie Ripke from the CDC Foundation, who's presenting on behalf of colleagues from Uganda who were not able to travel today from the Socioeconomic Data Center. Carrie?
All right. Good afternoon, everyone. I hope you have had the right amount of coffee to be here. So like Darcy said, my name is Carrie Ripke. I work with the CDC Foundation and work very closely alongside the CDC, some of my colleagues who are here today. And I'm going to provide you just a brief overview on how WaSH in healthcare facilities is financed and budgeted for with, in Uganda with a focus on two particular districts. This is Kabarole and Lira districts. So this work is part of a larger consultancy that we undertook in partnership with the Socioeconomic Data Center to better understand the landscape of financing and budgeting of WaSH in healthcare facilities in Uganda. And so we had sort of four main questions here, which you can read on the screen, but for the purposes of today, so I don't take up too much of our time, we're going to focus on these first two questions. First, how are the financing decisions made within the healthcare system in Uganda broadly, and then particularly in terms of WaSH in healthcare facilities? And then secondly, what are the existing costing and budgeting systems for WaSH in healthcare facilities at national, regional, and local government levels? So first, I guess I should orient you to the data that we used for this a little bit first before diving into our findings. So this was a combination of document review undertaken by our consulting colleagues, as well as a series of in-depth interviews with key stakeholders at national level with ministers, individuals in the Ministry of Health, Ministry of Water, Ministry of Planning and Finance, and Economic Development, as well as interviews with key stakeholders at the facility and district levels. So this looked like facility in charges, district and local government officials, health unit management committees in both of these districts. So with that orientation, how are budgets developed within the health sector in Uganda? And so I'm going to go through sort of three key points here. First is that priorities that set these budgets are determined by key strategic planning documents. So before we even begin this WaSH conversation, sometimes WaSH isn't part of the conversation, for example, in Uganda, where priorities are set within the National Development Plan, which has a 5-year cycle and currently does not include mention of WaSH specifically within institutions. And then a little bit more specifically within the Ministry of Health strategic plan is another place that sets the strategic priorities that could be funded. So once something is a priority, then we moved to what funds are available. And then these are constrained by the overall resource envelope that's put forth in Uganda's medium-term expenditure framework. So even if everyone agrees that WaSH in healthcare facilities is a priority, we have this ceiling of what is available to provide to folks based on what's available in this medium-term expenditure framework. So my first 2 points are a little depressing points at the moment, but I think our last one provides some hope within the budgeting process, is that budget development in Uganda is a highly consultative process at both national and subnational levels. So while WaSH and WaSH in healthcare facilities may not currently be talked about a lot in these processes, this provides us lots of opportunities to advocate for funding for WaSH in healthcare facilities. So engaging with stakeholders who are involved in this process, bringing them over to the team WaSH in healthcare facilities will provide us an opportunity to advocate for increased funding for WaSH in healthcare facilities. So just, I think I touched on most of these gaps in my last slide here, but highlighting again what we found about gaps within the budgeting process is that again, there's limited inclusion of institutional WaSH within the frameworks that set these budget priorities. As it currently stands, there's a lack of advocacy for WaSH in healthcare facilities within the budget consultation process. And then what resources there are available? Very few. There's limited flexibility to adopt budgets for facility needs. So there's a very strict formula for healthcare facilities to follow of 10% can be used for WaSH in healthcare facilities, and that doesn't change depending on your facility. It's really just set by what level of healthcare facility you are. So some increased flexibility to better meet facilities' needs would address some of the challenges we're facing. And then finally, there aren't tools or templates for budgeting needs at the facility level. So many facilities have conversations about how they should plan and prioritize, but they haven't been provided with resources from their district health officials or others to more strategically think about this. So then quickly pivoting into financing. So for those of you like me who are not economists, as I dove into this process, needed to learn about sort of two quick overviews of funding categories. One, which is on budget, which is financing that's appropriated by the national government and passes through the central government treasury. And then second, you have off budget, which are resources that don't pass through the central government treasury. So we found that in Uganda, the majority of financing comes through off budget, but let's touch about on budget first here. So again, on budget, this was approximately 9 different financing streams that we were able to identify. The majority of them came through the Ministry of Health, but a few of them came from the Ministry of Water and other entities. And some of our development partner support is also provided on budget, but again, the majority of this is off budget. So again, off budget, we had 22 different financing streams that came from off budget support. These include international non-governmental organizations, local CSOs, or private sector partners, which again, were a very small portion of the different financing streams here. So what gaps did we see here? Was that on-budget financing is currently insufficient to meet WaSH needs within healthcare facilities. I tried to pull up the number here. Uganda has taken the opportunity to develop this costed roadmap that Darcy talked about, and I think there's a $180 million gap to get all facilities up to basic service level by the 2030 Sustainable Development Goals. So on-budget financing is not currently enough. We don't see enough private sector engagement and financing. We had a few ad hoc contributions during COVID, which was included in our study period, but not sustainable multi-time contributions. Then another challenge we noticed is that the funding streams are not well coordinated across national and subnational levels. So there are many, many folks contributing to infrastructure, but not many folks contributing to O&M. And so this sort of creates a disparity that we see many times within our sector. Which leads me to, again, to my last point. This poses challenges for the sustainability of our infrastructure. So I want to pause there. Say thank you. Again, the data collection for this work was conducted by a team of consultants at the Socioeconomic Data Center based in Kampala. This work would not have been possible without them, as well as the Global WaSH team at the CDC. And thanks again to the Conrad and Hilton Foundation for their funding for this work. So over to Nepal.
Great. And we will be hosting a panel-style Q&A after all of our country case studies. So please write down your questions, and then we'll get to them at the end of all of our presentations. Up next, I am very pleased to welcome Dr. Sarbesh Sharma, who is the Director of the Management Division within the Department of Health Services within the Ministry of Health and Population. Dr. Sharma?
Thank you. Thank you, Darcy. Well, namaste and good afternoon to all. And I will start from the Constitution of Nepal. The Constitution of Nepal, it is written there that every citizen has a right of basic health services, and as well as no citizen should be deprived from emergency services, and the health services should be equitable and quality. So for the quality purpose, we have been doing the role of WaSH, because the WaSH in healthcare facility, which is crucial for the safe and functional healthcare facilities. As well as we formulate, Ministry of Health and Population formulates policy, and it allocates the budget also, as well as it monitor WaSH initiative across the healthcare facilities in Nepal. Ensure that every healthcare facility has access to need WaSH services. So Nepal is working further on the World Health Assembly 2019. It's recommended that conducting a comprehensive assessment and developing or implementing a roadmap as per the national context, and establishing the implementing minimum WaSH standard and service in the country, as well as setting a target and indicators within the policies for safe water, sanitation, and hygiene. So we have a principle also. There is a directive principle as well as priority assessment and actions also. For the directive principles, we have make all the health services that are promotive, preventive, and curative as well as rehabilitative in nature are safer in terms of improved quality of care and infection prevention and control. And second most point, make childbirth and primary health care safer, inclusive of reduced maternal mortality at delivery. Provide safe and efficient treatment services for a diarrheal disease. Means there is a NCD is very much in aggressive way because 80% of cases are now reported from NCDs. And we have to stop the spread of AMR surveillance within the environment, as well as build the resilience of healthcare facilities to work on emergency and disaster, as well as in a climate change also. So the key communities suffers from the harm associated with WaSH provision and provide a role model to communicates for learning on safer WaSH and contribute the achievement of the Sustainable Development Goal 6 on WaSH and Global 3 on health by 2030. So in this process, we have a collaboration with TDH, and the TDH has conducted a detailed costing exercise for WaSH in healthcare facilities in one of the municipality of Bardia district, that is Ababa. And this exercise provide invaluable data on capital cost, annual operation, as well as maintenance cost, and many more. The outcomes of this collaboration served as a basis for our policy development and have been integrated into our national roadmap for WaSH in healthcare facility. This is a prime example of how partnership can accelerate progress and bring us closer to our goal of universal access to WaSH in healthcare facilities. So why there is a need of costed roadmap in Nepal? As we strive our universal access to WaSH in healthcare facility, we need detailed actionable financial plan. Only 1/3 of the countries globally have national costed roadmap on WaSH in healthcare facility. Nepal aims to be among those leading in these changes. A costed roadmap not only provides a financial blueprint, but also aligns stakeholders, ensuring that we are working towards the same goal. So the TDS contributed on MOH, Ministry of Health and Population Roadmap by conducting a comprehensive costing exercise in Ababa municipality, providing us with invaluable data. This data has been instrumental in shaping our understanding of the real cost involved in WaSH services, from capital cost to annual Q&M cost. Their workshops as a model demonstrative how localized data can inform or enrich national policies. Integrating data into policies. The data that has been generated from the municipal level has been incorporated into the national policy data. The data from TDH has been integrated into Nepal National Roadmap for WaSH in healthcare facilities. This has not only informed for budgeting allocation, but also enriched our policy guidelines, particularly in the areas of operation and maintenance. It is testament to how evidence-based policy making can lead to more effective and sustainable outcomes. At last, as we move forward, our focus will be on implementing the roadmap, monitoring its impact, and continuously updating it based on new data and insights. We are excited about the potential for further collaborating and learning, including from our extreme partner of Uganda and Zimbabwe. And we are also thankful to the Swiss Water and Sanitation Consortium for this support. Thank you. Thank you very much.
Thank you, Dr. Sharma. We're very pleased that you were able to travel from Nepal to be with us today. Next up, I have a video from our colleagues from UNICEF Zimbabwe, who unfortunately are not able to join us, but we're very pleased that they were able to record their remarks to share with you today.
Hello everyone. Thank you very much for the opportunity to share our experience from Zimbabwe. My name is Mitsuaki Hirai, and I'm WaSH specialist at UNICEF Zimbabwe. This presentation focuses on the development and use of WaSH-Fit costing tool. Just to provide some context, I would like to share some of the key progress made in Zimbabwe on WaSH in healthcare facilities. The Water and Sanitation for Health Facility Improvement Tool, WaSH-Fit, was first used as part of the COVID-19 response in 2020. From 2021, UNICEF has supported the government to roll out WaSH Fit in 100 healthcare facilities. For this project, we have conducted baseline, midline, and endline assessment to assess any improvements in WaSH service availability and WaSH Fit users' perceptions. A costing tool was developed in 2022 to estimate a national budget requirement for WaSH in healthcare facilities work. This is the main topic for today. Using BOQs of the 100 healthcare facilities, a WaSH Fit costing tool was developed initially as an Excel-based tool, and later it was digitized and incorporated into the Ministry of Health and Child Care's information systems. The costing tool can estimate costs on infrastructure upgrades, training, and supplies. Our preliminary estimation of the required national budget suggests that we need around $116 million to implement WaSH Fit nationally. The investment in Zimbabwe for WaSH Fit implementation has been approximately $4 to $5 million, so a quite substantial budget increase would be needed. This slide presents the interface of WaSH Fit costing tool that we developed. Based on key parameters such as urban-rural location, facility type, and WaSH Fit assessment scores, it can estimate the budget requirements of infrastructure upgrades, training, and supplies. Basically, once you enter information in orange and green highlighted cells, figures automatically appear in light blue cells. CapEx represents capital expenditures or infrastructure upgrades. SoftX represents soft expenditures or training cost. And OpEx represents operational expenditure or supplies. A total cost can be calculated as a sum of these three components. One of the key challenges with this costing tool is that data are based on the BOQs, bill of quantities, from 100 healthcare facilities only, so extrapolating data may need to be carefully done. As Zimbabwe is aiming to expand WaSH Fit, additional data may be collected to enhance the accuracy of estimated budget by the costing tool. The costing estimates can also be summarized by the facility type. This table shows the breakdown of WaSH Fit budget requirements by 4 categories: urban and rural, primary healthcare facilities, and hospitals. We estimated a unit cost of healthcare facility for these categories and multiplied it by the number of healthcare facilities in Zimbabwe. This cost breakdown helps the government to have more focused discussions on budget mobilization and allocation. Here are some of the key steps going forward. Programmatically, we want to use the tool for advocacy and program planning. We also want to generate additional evidence by exploring key drivers of long-term sustainability of WaSH in healthcare facilities. Lastly, we want to ensure that the costing tool manual is utilized for sustainability and ownership by the government. Before I conclude, I want to share that WaSH Fit has been making a difference on the ground. On this slide, one of the healthcare facility staff shared what she observed in her healthcare facility. To continue improving WaSH conditions in healthcare facilities, we need to understand financial requirements. And the WaSH Fit costing tool is one way to provide insights into how to estimate the required budget for resource mobilization and WaSH Fit expansion. Thank you very much for your attention. In case of any questions, Tariro Mabi, WaSH specialist at UNICEF Zimbabwe, and I are available to answer any questions. Thank you very much.
Great. So what we'll do now, we'll have a brief panel Q&A where I'll welcome our speakers back up to the front. We do have a virtual audience today, so if you have a question, I ask that you would come up to the microphone here, we can form a queue, and ask questions to our panel that way. So please. I guess I'll kick us off, well, if our audience is going to be shy. I wonder if you could both speak to what are some of the challenges that you've overcome in your work in terms of collaborating with, you're receiving data from diverse sources, you're interacting with a broad range of partners. What are some of the things that have been challenging about that, and then how have you overcome those difficulties?
Thank you, Darcy, for the question. It is slightly challenging for the data because the data from the health post level or the municipal level, because we couldn't get the data from the municipal level. All the data of WaSH, it comes from health facility level. So the coordination between the health facility level as well as for municipal level is slightly difficult. So mainly the data which is collected from the health facility level, that is come under DHIS2, that comes to the central and federal system, and then we discuss and we further plan and implement that data for the process of WaSH in the health facility level. So in this way, so that is slightly challenging to get the data from the local level due to this federal system, because previously we have not a federal system. Right now Nepal is a federal democratic country, so there is a 3-tier of government, so there is slightly difficult. This is the challenge over us. Thank you.
I guess it's kind of encouraging to hear that we're having the same problem, so we should perhaps chat more afterwards. I think another challenge that we had, and I didn't really present on this information, was looking at what current budget amounts are available for facilities. And one of the challenges that we saw is that within the various lines for funding within Uganda's program-based budget scheme, that there's not one particular line for WaSH and healthcare facilities. So this, you have little parts of funding for WaSH and healthcare facilities in lots of different pockets, but because there's not one dedicated funding line, there's no real way for us to quickly and easily know how much is being allocated to WaSH and healthcare facilities. So getting these calculations of what's being spent and what's needed is challenging, and why I'm not presenting on the numbers, since we haven't been able to put that together yet. And so, yeah, I think that's what comes to mind.
For the financial budgeting, the center, the Ministry of Health and Population, they provide budget to the local level. There is the estimated cost, because we are in the process of making a costed roadmap with the support of UNICEF and WHO. But we have some Nepal Health Facility Survey report. It says that it needs we have 7 provinces. So in each province, it needs 1 billion per year for the WaSH and healthcare facilities. So this is a huge amount of budget. Maybe for 7 years time frame, we need a $49 billion for the WaSH and healthcare facility. So it's a huge amount. So we need of the budget from the donor also to provide this WaSH facility to the healthcare facility. So this is the big challenge of it, because right now we are also in the recession phase, because we don't have money. We are in the recession phase of this globalization. So this is the problem.
Peter from University of Northwestern Switzerland. I have a question about changes of cost in time, because the cost is a kind of, I think it changes a lot, fluctuating depending on geopolitical situation. So how do you manage that, like inflation, cost variations, especially for hardware, which is sometimes can change extremely within a short period of time?
So it is that was approx budget. So due to the inflation, due to the geo-economic politics, it will change. But we have a plan to make a costed roadmap. So we get actual finding from that. But it won't be a final decision of that budget. It needs this is the budget for our health facility. It will be slightly changeable also. So we can't say right now, this is the price code that we need this much of money for the health facility. But approximately 40 to 50 billion money will be needed for us.
Yeah, and I think we were looking less specifically at that. Most of our work was retrospective, looking at what has been spent and allocated over the past few years, but we did notice major fluctuations due to COVID. Again, that was in our sample, and so we intentionally wanted to look at before, during, and after COVID to try to capture some of those changes of, at least it seems like there was a lot of increased spending for WaSH and healthcare facilities and energy behind that. So I'll be eager to see if that manifests in any sustainable increase in funding. So, yeah.
Great. We have a question that's come in from the chat from Lindsay Denny, who asks, based on your experiences with these costing studies and tools, how applicable do you think your experiences are for countries who have not undertaken this work? Is it translatable?
Yeah, I would say our work is translatable. I think how one would approach it definitely depends on your political and economic context of talking about whether it's things are allocated at a federal level or if there's a lot more autonomy at a district or different level. But I think the process of identifying key actors, speaking to key actors across different levels, and mapping out sort of the systems analysis of who's involved and how decisions are made is a really helpful tool for figuring out also who needs to get this budgeting and costing information that our colleagues are generating through their work. So perhaps different people, but I will always advocate for talking with folks and trying to better understand the environments where we're trying to influence change.
It's the same for me also.
Please.
Hi, Claire Chase from the World Bank. We're also doing a lot of work on costing and WaSH and healthcare facilities, so it would be great to collaborate with your teams on that work, also with UNICEF and WHO. But my question is, are you accounting for population growth and new health facilities? This is a question that we have had in our scenarios that we've put together, because especially for the Africa region where we see huge population growth, I mean, even with household sanitation and water supply, we're not able to keep up with population growth, and access is actually declining in the region. So I think that's a consideration that we need to, and I've spoken with our health colleagues, and actually they don't have estimates of number of healthcare facilities that will be needed, and also how populations are moving and migrating to different areas, which will maybe require a different distribution of healthcare facilities. So I think if we're going to get serious about costing, we also need to start thinking about these things. So just wanted to hear if you had any thoughts on this and how we could maybe incorporate that into the estimates.
For the health facility, right now in Nepal, due to the federalization, a lot of municipal level, they have started their own hospitals. So there are a lot of hospital is grown up this time, because the new health facilities, and our previous Prime Minister also established 752 hospitals in the municipal level. So he introduced these hospitals. So there are a lot of challenges. Bank also help us for the instrument and all the biomedical equipments, and for the WaSH facility also. So with the support of external EDPs, we are planning to improve our health and this healthcare waste management, as well as WaSH facility in the health facility. This is our process of going.
Yeah, I think, again, we've looked less specifically into estimating these numbers, but these are great questions. We're hoping to, later this year, hold a workshop and disseminate these findings and validate them with folks in the Ministry of Health, as well as other stakeholders that we've already spoken to. And so I think that these are great questions to pose back to them about any estimates that they have, and ensuring that maybe the numbers that we're advocating for are in line with that. And I'm now also very interested to go back to the methodology for Uganda's costed roadmap, because I do think that those were estimates just for the facilities that exist now and just the public facilities. And I think from what I've seen, at least in these two districts, there's been a real explosion of private facilities as well, and that's not even often part of the conversation. And I think that's an important thing to consider as well. So thank you.
Please, yes.
Thank you for that. It was very nice to see in the Uganda case study how you linked in the wider public finance structures and discussions, and I don't see that often in our talk of how it integrates into a whole system. Have you looked into how the question of financing WaSH and healthcare facilities fits in with the wider question of just financing health through insurance-based or other opportunities to finance the...
No, and I think that that is a really promising opportunity because I think, again, one of our conclusions is there's not enough money here, and even with excellent support from various types of donors and partners, there's still this really large gap. And so I think, yeah, I really like this idea of exploring what other options might be feasible and sustainable for, again, accounting for this growth in populations that we'll have. So
Great.
Love to hear more from you because I am not an economist, so I am learning as I go here and I need to learn from others.
Great. Ryan, do you want to take the last question and then we'll transition?
Yeah, thanks for this. So we're starting to see a lot more costing data, budgeting data coming out, and we can start to figure out in countries how much it costs to improve services to basic services. I'm wondering if you're seeing in countries also an interest in what are the actual benefits of having these improved services, whether that's through improved health outcomes, healthcare-acquired infections, or other measures, or other metrics like mental well-being or patient satisfaction, or et cetera. Do you see politicians and government makers looking for that information as a means of comparing, you know, why should I invest in WaSH and healthcare facilities versus something else? I'd love to hear your reflections on that.
Yeah, I think that this is a question that we come back to every time that's the type of work that I think folks want to hear and want to do because, again, there are not millions, but many folks on our politicians' doorsteps asking for money and advocating for things that really do deserve funding. And so I think earlier this year at All Systems, there was conversation about sort of our role as a sector is to generate evidence that's digestible and accessible to help politicians make decisions. And so I think that presenting things in that way of the costs and benefits in a way that is more digestible could be very useful, especially for advocacy. So yes, let's find funding and do it.
Dr. Sharma, I'll give you the last word here.
Okay, for this, it is not only the government can do everything, so we need EDPs as well. So this is a joint collaboration of EDPs and government. Then only we can make our health facility better in health, WaSH. Otherwise, it's difficult for the government singly to do everything in this world because this is a time of recession and we can't do everything with our own. So we need a partner. So we invite all the partners who wanted to work in Nepal, so you can all come and help us. Thank you for that.
Great. Well, thank you again to our wonderful speakers.
We can better coordinate and help you in a way that is helpful. So I have many more questions.
Thank you.
Okay. We are going to transition now to breakout discussions. So I will ask you to form groups of approximately 6 to 8 people. If you're here with colleagues from your country or your organization, I encourage you to branch out and meet new people so that we can get a diversity of perspectives within each group. If you are here with me as a note taker or facilitator, can you please raise your hand so that people can know who you are? Great. So we have designated facilitators and note takers who will help guide you through this discussion. We have 4 topics prepared that we would like you to cover. The first is, what are current approaches used for costing WaSH and healthcare facilities in your organization or in your context? How do stakeholders apply cost data for policy and practice? What are the biggest barriers to applying cost data? And what strategies can overcome these barriers? I see we've already lost a few, but I really do encourage you to stick around. We're really hoping to capture your learnings here so that we can disseminate out all of the expertise in this room to people who are not able to attend this event in person. So if I could get one group to form up here in the front, I think we're looking at probably 2 or 3 groups. One group on the back left, and then one group on the front right here.
And every group will have to talk through the 4 questions. Right?
Correct, yes. I don't know how to do that. Okay, I brought pen more as well. Ryan's coming back on tape, if you want to put that on the wall, so I can start opening these. And I worked with Gary on I worked with Gary on the that's it. Sometimes people like to see the interactiveness as they're going. Tell you what, I'll run the interactive notes, and then if you want to take away really detailed notes on the computer. Great.
I have some faces here, but I love to just start by introducing everybody. I like to know them, so if you could go around and say your name, who you're with, and maybe a brief bullet on what you do with this watch.
I can start. My name is Sandhya. I'm with SNB working in Indonesia. I'm watch program manager.
Hi, I'm Isaac Ngere. I'm working for State University, but based in Kenya, and also watching the program.
My name is Darcy. I'm with the
So I look after the
My name is
healthcare facility as well as management,
I'm working
as well as infrastructure of health facilities and supply chain management.
Hi, I'm Ryan. I'm the water institute.
So I look all
Sneaking over there.
Yeah.
Hello, my name is Andy. I'm also from Ababa. We are supporting Ministry of Health to develop a costed roadmap. And during the costing, we tried so many tools here that
I'm based in Chad. And I don't have very much
also
experience
we
at all
put the
with
reference of
those.
that
Just
project
a few small private ones
right
that
now.
we've worked with our local
And
partners.
I had chance to
I don't think I have much to contribute, but I'm happy to learn
research
from all.
paper.
We also would love to hear about your daily needs. So as an organization that doesn't actively provide data, if you're someone who has a need to receive data from others, your contribution
and
would
they
be
are
valuable.
developing uniform.
Yes,
And we are
second
using
unit for
that
the
also.
water
And
project
it
is
seems very
not
comparable
called
to that hill area and from that model. And we are taking all the three and we have it is almost final phase of that foster
And
program.
I'm still Carrie. I work at the Macy Foundation, primarily in Washington facilities work. In Uganda and Ethiopia, and some projects here in the United States. So I guess we'll start, we sort of have 4 buckets of questions, and you can go in a different direction if some of these seem like you don't have a lot to share. But first, talking about what are, I guess maybe the first question is, how many of you collect costing data for healthcare facilities? Okay. Would you be willing to share sort of what your organization does, what types of data you collect, how do you share it with others?
So in Indonesia, and is implementing this program, so it's a citywide sanitation program, and part of the in the healthcare facilities. So when we started the initiative back in 2000,
So I probably might dive in maybe to
there
the
was
second
the
question.
WaSH gate
How does your organization country
So
use
we
data for WaSH?
developed our own
Use cost data for WaSH health
for
facilities,
WaSH provision and
policy and practice.
collected
I feel like we got a good example from Paul already about
for
using that data to
on
inform policy.
WaSH.
I would love to
So
hear,
if
I
you
know a lot of
don't
us
have
sounds like are new to the area, but I'd love to hear
then
from other
you
perspectives
should
as well.
construct
Share anything.
new things. So we identify the cost and then to upgrade as well, and then to ensure the supplies. And also we added some components on training, health promotion, some more. So we finalized in several healthcare facilities. And during the pilot, the WHO and UNICEF introduced the WaSH tool. So at national level, we ended up collaborating with them. So the national roadmap and the national constitution actually captured some data collected at state level. So the national roadmap considered data collected by UNICEF, by WHO, in our own so at national level, we worked with the Ministry of Health to develop the cost and the roadmap. So it was a participatory series of RGHI interviews and disseminated the
Okay, so understanding what
roadmap
needs are to be able to then choose that.
we can distribute health offices.
Really, again, that sort of touches on the question of how is information shared, and I'm hearing from you that like it started very early in the process of having the stakeholder buy-in. Get excited. I don't want to put you on the spot since I know you said your colleagues or other partners might be about it. Are you able to speak to at all what sort of costing data folks in your consortium are collecting?
Well, basically, yes, but we already told it because our partner is 30 zones in West Africa, so I don't have to repeat this all in that call. Right, so they must So, but maybe I just want to kind of bring a little bit of experience on cost in healthcare, but from schools, Palestine, where it's another partner we work with, and therefore one of the bigger questions is to try to distinguish between the costs of maintenance of infrastructure, where we specifically focus on, and possibilities of doing preventive maintenance and try to
So I know that for our analysis, we were aware that like the Ministry of Water is funding some level of
saved on the costs because of all the water services happening there, so
the majority
do something.
okay, so the acknowledgement that other ministries
It costs a lot just
are supporting it is
So
there. I
therefore,
don't know
this
how
kind of
that's
specific focusing
translated
on
into
there we are still like in the process of
Do you have any information on where you're development
to capture the situation together with this Ministry of Education.
Estimated cost.
I'm curious about how that work came about. That sounds, is that something that your organization was interested in, or is that something that came from the Ministry of Education, that they wanted to know, well, why should we invest in preventative maintenance versus preventive?
It came out of the just whole discussion about maintenance because it was identified much as one of the issues. So together with the partners. So, and then discussion how we address the maintenance issues and the financial costs. So who's responsible because the Palestine is also very complicated government situation. So there was a lot of discussion about who's actually paying for that. There's the infrastructure department, there's education, there's municipality, there's municipal house, is there infrastructure department, so it's kind of complex. So, and there we brought up discussion about preventative maintenance.
Otherwise, the pipe system, big system, community system
Save
that
the cost on maintenance to make it more affordable.
that's a
So therefore,
big proportion of this cost will go to the other ministries.
So in the concept,
Others
does it
have
say
any
like
experience with costing, or do we put the question and see,
Yeah,
do any of your organizations currently get costing data from others
ministry wise also.
to inform your work?
I guess one of the questions were also coming from how does the coordination happen between departments?
I think like so we don't have posting data for hospitals. Also the most things including WaSH. Because it's
really
not
giving
connected and
costing, it doesn't have to be just
I think giving an experience of what we see, there's a time we do WaSH evaluations for several programs, and one of the programs we wanted to evaluate was WaSH tools. So we wanted to do a costing, just understand how much it costs to set up a hygiene station. And the process of one getting data is almost impossible because the way procurement is done, the way the costing is done in our country is a little bit interesting. So most of the time data was not forthcoming, and even from most of the organizations, they were not really understanding how that data needs to be presented. Because apparently even procurement, like the cost of items, sometimes hidden cost which people don't understand. So they just, I think, generally what I saw is general availability of data, and even when it's there, then it's really difficult process sort of trying to
I'm curious if others in other contexts have had that, maybe not necessarily in WaSH or in WaSH healthcare facilities, but had that challenge of like procurement cost fees and maintenance services. I'm curious, have you found any success in ways to overcome that or promising solutions for that?
So it's not easy. We first went to institutions like schools, asking them to give us costs, and they were not able to cause those procurement issues. So something is documented as costing $100, but in essence, it was supposed to cost $50. So no one wants to talk about it. Then we went to the next step now to the supplier who provided this station, who provided the tap, who provided the water container, who do you buy water from? And then even in those areas, we still give various rates, like one person will give a different rate. Few organizations will give you the actual cost, but most of them is either business secret, so they don't want to, provide the cost because someone else will use that to give
I'm
them.
interested in the
Or
role of
sometimes
the
it's
discussion of
because when they sell to government, they double the price. So they don't want to give you the actual amount because when they sell to government, they want to make a big profit, so they double the price.
Decentralized financing for many government services, but healthcare and school are still siloed, and that creates some tension on the ground between sharing budgets. Used to there, Ministry of Water, is all working within programs that you encounter as a project, successful ways.
Does those projects have
some coordination there is
for
that challenge.
the money that will be spent and how much that project will cost? So I'm going to nudge you a little bit to think about, finance runs the world, and so how do you interact with that in your organization? Because it must be there somewhere. Someone is tracking that. Who is that within your organization? And how do you interact with that?
So I do in a general statement in relation to the concerns of Asian healthcare facilities. You want us to just tell you general kind of thing, not necessarily in relation to Washington.
I suppose if you can be specific, that would be great, but if you only know just
Because for me, I don't do anything.
I just one example of health facility that had its own board.
But I thought maybe you wanted to know in our organizations how the financing scheme done, who is responsible. Okay, so for my normal work, because yes, I'm a natural researcher. So yes, any project that I get, we have a finance department who goes with a lot of organizations, and we have specific budget lines allocated for specific activities or expenditure. So you can only request on those budget lines, and you can't go beyond those ceilings. And with accounting for it, depending on that particular activity, either you are providing, in the case of Ghana, VAT receipt, not any other receipt, other than VAT receipt. If it's also something to do with procurement, then with the procurement people, so you will have to just give them the technical thing that you want, the specifications. Then they will have to float it out, get this or cost, and they will now determine who that one, and after they link with the finance and also audit when the supplies, whatever that you procured.
Yeah, and it goes back to our question of prioritization, that we increase the profile of WaSH in the prioritization.
And I hope that's the role for the NGO and the CSO that we can talk about that.
So looking at the question, I thought maybe you are looking at service providers, services. How they cost and washing whatever. Like you take my project for example, you provide facilities for healthcare. Yeah, water facilities for healthcare. But we don't do
Your question is very valid.
what is it with the design?
Issue is to use the government design
and then ask for an update to submit it. We request for how much it will cost
after
to
4 days.
construct that facility
There is
for a particular
so
so they will bring their cost, and depending on where you are going to the cost will vary. They will do that and cost that to leverage that capital to be cheaper than those in the area. So you won't get one
this committee,
price
especially
for all the
under the leadership of director,
but of course, because
head
the
of the
different
services,
and then you evaluate
now we advocate if
this
you want
cost
to
equal to
some support for the vaccination,
that type of it is that after I have
other
provided the
activities,
facility,
we must have some this
who is
percentage
going
of
to
the
do the
amount.
work on it? And that is where we work
This
with
percentage of the amount.
authorities to let them
What
know that,
services?
yes, we have this
And
facility,
because of that,
but over the line,
now we have
this facility, you need this
the
amount.
budget is coming through the ministry. That is always
Sometimes you don't have the
through the
budget
ministry, through the
to
government. We
provide
have
the
enough.
overhead.
Yeah, in that way, we are
Institutions and then society, the section for the community, how they want the community to support them. But we don't come at that point. We just do the facility and we provide them, we tell them that this is how much we in the facility. Let's say every year.
So I apologize if I didn't understand, but are you providing that estimate on how much the O&M will cost over time, or is someone else providing that?
So we have one of our consultants who does the life cycle costing for us. They will get the figure based on solar, is how much we need for let's say every year for the next 10 years. It's based on the rates that we have been paid the bills, and it's how much we need for the
infrastructure building and everything like that.
but that one goes.
The vision is not on
Let's say
the
Ghana success for their money.
That is the problem. So advocacy should be needed. So we have training as well as advocacy for the local leaders.
Usually we don't do institutional WaSH, but it's sort of come
So I have a question,
I think because we are a small organization, we do particularly in second, which is,
okay, so
but we had
challenge of
most of the places where we work, there aren't any hospitals, 5 days healthcare facilities, and so in
What is the role of
places,
data in the advocacy process? Is
one
it
place in Niger,
a lack of data
or we are partners, so we
data
have
are
these
already told
hospitals that are in the communities where we were already providing water, and
separate
they
data
asked
entity.
if we could give a check system or do an individual system for these two hospitals in each place. And so they were the ones who came to us with the budget and were like, is it possible to add these into our
That is
existing
the problem. The
plan
data
to meet
services is not
medical
we can certain
needs
data
of
from
the community?
We can data from
And
municipal level.
so we just went by,
But to
again,
educate the
like you're
data
saying,
at the
basic,
national level, that is a
what would
problem.
you do to do, what would you need to provide water?
System
Like a tap dance or connect to
That is the
existing
main
water
problem. So
systems that are.
we are thinking that there should be an intra-operable
Usually
mechanism.
solar
for
panels,
data
so we know the basic
Then only we
cost
can
for
go forward. Otherwise it will be a
general water
data will come
project.
from a different side.
Pumps,
And
if
where
we
do
need a
that
submersible
go?
pump, if it's
Different
connected tap
hazards.
dams, all
So
the
we
piping,
have to
all of that
educate
stuff, we have
that. That is the
general
problem.
information just for local markets.
There
There was one case where we completed a water system near enough to an area where the government had already planned to build a hospital or a health center, and because there was access to water, because of the project that we did, the government actually came and built a health center right next to it because we agreed to connect it to them. So we didn't do anything beyond provide the water, and they came in with the other side. So I thought we were really excited about that, seeing the public-private kind of partnership there. But again, I would agree also that a it's just what we know generally from the water side, basic water translates over.
Understanding that it is because they are.
So, I mean, my experience
For
is
example,
also that working for different
data
organizations,
collecting for the
what usually happens is that, I mean,
healthcare
most of these organizations have a supply
even if it's open boarding,
supply the
they
department
consider
that
it
is
safe, but
procurement and identification of supplies, but also advice on prices. This includes research as well. So usually what we do is, I mean, we have like costs at two levels. So there is the programmatic cost, which is really about the software activities like training people or building the capacity of government to we want to conduct. So I mean, then there are those activities which are supply related. So for instance, you want to chua pipes or whatever you call it, a warehouse or transmission facility. So where supplies is involved, we usually line up supply colleagues. They are the ones who can, they have a catalog of prices for every supplies.
What kind of data is supporting?
Exactly.
Is it like the amount of
money? So when you are planning
adverse health outcomes that are presented by
countries where
I kind of feel like it's probably cost. But I'm curious.
I mean, who would say, I want to construct 10 workers, how am I going to start with this? And they will give them prices and then they will be able to get the price for construction. Yeah. So I think, and usually the supply police work with suppliers within the country to they make assessments to understand what are the costs of supplies within the country. So they make some calculations to take account of what we're saying that sometimes in the rural area the prices may be much a lot higher than within the capital because of variations in terms of distance, inflation and so on. So they factor all those things to give a reasonable price for the cost of supplies. So they work with us, but also working with the relevant ministries, for instance, it is health, they work with the Ministry of Health, because the Ministry of Health have also a department, they deal with supplies as well. So they usually have prices as well, what's required for supplies for programs, including water. So I think working closely with the Ministry of Health is very important because they understand. So this is what they do.
For us, we also work through local partners. So they set up their budget, and then we will sit with them and they discuss, and we take into consideration the annual inflation. So if the inflation is of 10%, we will factor that in the budget for any system, and we have like a catalog also of price for each individual system that we want to build in the community or in the healthcare facility. So we know that for a whole across, if we build it in an institution or in community, we know that it will cost us so much. And for O&M, most of our cost comes from transport. So because people have to travel from the local office to different sites where they have to do repair. So a big chunk of the cost comes from transport that people use to move across. So we don't really dictates which suppliers that they have to use. I think our partner have established a relationship with the local the suppliers. They go and procure those. They have like different suppliers where they go, for example, procure pump, where we buy pipes or other equipment which are needed for. But with the different type of system, we also require the community to contribute as that system is being built, so that there is a sense of ownership as the system is being built. So, for example, with the rain tank, we expect the community to contribute. We don't ask them to bring money because, money has a lot of stories behind it. So they will bring material. So
we say maybe bring sand, maybe bring cement. So they will buy it and they will just bring it on site. We never expect them to say, you will bring 100,000 US dollars for this to know. It's bring material, that's what is part of your contribution in the costing of that project. So that's how we work. And those budgets are reviewed annually. And since we are in the US, we do also put an exchange rate gain, just also to help us mitigate some things which might change after the budget has been approved. For example, or suddenly, in many of our African nations, the government will wake up in the morning and say, oh, the gas price goes up, without even alerting people properly. It goes up there. Those exchange rate gain can offset some of those kind of unexpected budgetary situations. So that's how we work with our local
approaches for costing. We just cost for capital. Just to install a facility. We don't look at
to show broken things and stuff. We had one district health director
installation take.
Most of them take 1 year, 2 years, then they start to break down. He was not even aware that encouraging people to say, look at what facilities in health institutions and that is the jurisdiction. So right at the big schools the next time we had the meeting, I was so happy to show us pictures of the things being repaired and also, even though that was like the way we are talking about it, he was compelled by the evidence we provided from the ground on how bad things are. Feeling like, okay, this is another district that has everything
who are served by this WaSH. Sometimes like in a healthcare facility, depending on the level of facility. Sometimes we construct one hall for a case of say 500 people in the village. But there are other instances maybe where that facility will serve, the WaSH facility will serve like 2,000 people. And so I think it's important to bear in mind that in such a case, one hall isn't enough. Maybe think about water sources, so really think about how much water does one household need in such a facility, assuming you get like 500 people in that facility, how much water do we need instead of supply the water if you have sewer systems, sanitation facilities, or even just a pump for cooking, drinking, cleaning, and all of that. So I think factoring all of these kind of costs in terms of how many people does this facility serve is really important, because often we find that the available water sources need to water households, especially where the water table is low, where you pump water and then after some time you have to wait for, I think it's in this after like 1 hour, 2 hours, they go dry and then wait until the water flows again. So yeah, I think it's important to link the service to the number of people that it serves to make sure that this project is service. So that approach of costing, so I think it's really important.
It is also you can find out how much excited we all are trying to figure out. You start like angels, you start to work together, and I feel like watch it. You have to do estimates. You have not even but don't have like complete information. Keep on trying to do that station base. So you have to do estimates.
I also wanted to ask.
Usually it takes about 1 year to do
the costing data, the data that you were able to get. Did you support getting the data? Here's one, right? Did you face challenges with actually getting the costing data? Because we were trying to do costing for the Washington project that was largely funded by donations from NGOs. We could not get people to share their data. That was a challenge.
So there's a lot of uncertainty. yes,
I joined,
because this project size is that we start on the project quite in advance before you're actually able to implement it. And then you have to bring insights for maintenance and long-term perspective of that. So where you have again a certain calculation growth of systems in place, so if it's all planned in advance, it's
clearly there was a
difficult
such
to
a
make
big
properly, so
issue
it's
of
at the end of
the ownership of the data, like how the data is collected, this is the costings, everything, well, this can't be this big, or this can't be this
it's
low.
not easy.
Who generated this, on whose interest, you know, those kind of things. But then what we are doing in that meeting is that, okay, fine, then what is the best way to do it? Because they've seen that, okay, maybe they may not like it, or they may not have, we agree that it may not have been done as perfectly as it was,
It's changing now, so
but then show us the best way, what is how to do it. And then what we agreed in that meeting was to actually do the scope in the way that it was being done.
therefore,
And so now that it was not the time, it was all correct. So they had no choice but to agree with the way that had been agreed in multiple meetings. So it's like using the data sources and being present in the process and then, you know, co-creating that sort of data generation with this
And I
data.
think one of the things that
Co-creating process and being transparent.
Exactly, along all the process and being present. I think that's
really
that's
using
very
the
important.
different
Nothing moves as you like. It requires certain amount of efficient systems and SI. Making sure that these funds integrated in a way which will continue because like you said, I mean, most of the program will do 1 year and then after 1 year you don't have funds to continue with managing the costed programs, so making sure that advocacy data level liaison, we also have very clear linkages with the political parties.
Most context, who is the consumer of the costing data? Because you have been hearing experiences that
Yes.
I'm thinking maybe one of the reasons why we
Who is leading and who is interest?
we were looking for this data as an M&D kind of process.
Any other thoughts? I mean, have you,
We
I guess
sort
that
of
was
were
the
writing
same
out a
question
manual
that
on how to maintain and manage
was
the
there like
stations. So we
getting
wanted
the
to
national
advise
government
partners that if
involved, that
you want to
helped
set
at all,
up
or
a
is that
station,
not?
this is the kind of capital outlay we're looking at. This is the kind of amount of money we
For,
need for operations.
facilitating
And I think that's where we had a lot of
organizations to be
success in
willing to share their
what I
costing
would
data.
call would be data costing. So in most instances, we will be costing who is the consumer of that data. These are very important.
Can I pull together a few points that have been made and ask you a question? So earlier we heard people saying that you have suppliers who have known costs, you have prices, you have all of this upfront information about the system. But then these challenges on estimating long-term O&M costs. What is the gap in leveraging this rich information that we can use upfront to estimating long-term O&M costs? Is the data that we have, that we know for upfront, can we apply that to O&M? And why not?
Directly to the sub-national level, only national level means only.
Consecutive definite a lot of change in the last decade. How long has this hospital exist?
Good collaboration.
I hope that there will be a hospital there forever. I mean, so trying to estimate the cost for maintaining the system, upgrading it eventually when the population grows. I mean, there's so much that you don't know, and it's really hard to measure. Even if you do know everything, you don't know, are the people in the hospital, do you have a big team that's actually going to take care of the systems, or do you have someone who's going to just like use it as hard as they can until it breaks quickly? I mean, it's hard to know even that small amount of, whereas it's easy to know this pipe costs this much. If there's inflation, it'll cost this much. Like that's just, those are the facts that are there, and to plan for something very unpredictable is definitely.
Because it needs to be owned, completely led by.
Great, I can see some perspective. Anyone else?
Yeah, so the best we can do is maybe in the short term, as you said, because prices can change anytime, especially in our and inflation and other things can change the prices. So I think the most time they have to a short term, up to about 5 years. Beyond that, I think the healthcare facility itself,
What purpose are
based
you
on the
generating that on?
curriculum, should be able to It's really important. If it's costness, if it's going to come up, in the next 10 years, you are planning for very strong and then they can think that's where you got a good political interest. One thing that we saw there's not going to be sufficient resources to be allocated in the MPs that's presented, they can also prioritize and access what is the availability and also one of the things that we are working with them is to include the WaSH some of them.
So I think, the overall goal
and
of
if
the
it is
session
there,
is
then
about how do
they
we move
budget
from
for the ONM
gathering
cost,
data.
the monitor will show
There are tools
if
and
the WaSH
ways to do
is
that.
working, if you don't.
To getting to the point where the ministries are providing the budget to provide those services. So in your mind, what are some of the greatest barriers to overcoming that gap? So we have cost roadmaps, but we still need to get the funding to fill in that gap. So what is needed to kind of fill in that? That's the biggest question.
So
maybe not having the answers.
they are actually able to
Ultimately, no, finance is the last bit of if you get money will be funded by someone else. Because it is not a priority system.
Or if you see it's not going to happen for whatever situation you are, especially crisis areas.
Treatment protocol and
Right, so then we try to see how can we
ultimately
get the funds. So we are actually finding ways to cover it. We are also trying to cure it in 3 years at our project because we want to keep things going on. So I cover for the investments we should do in infrastructure.
One facility.
So this is kind of the process, but it has so much uncertainty in there, so which makes this plan discussion special analysis for Sorry,
It's just a question based on what she said. So as I said, I haven't done much adoption of healthcare facilities, but if you budget for OMN, the learning facilities at the hospital, my question is that OMN to provide it support, or are you giving it to? Is it working with you can personalize the provider of the facility, or you actually release the funds to the health facilities, the authorities? To me, I think if you release it to the health facilities, and it's likely that money will be used for something else and not necessarily for what it has been targeted to.
That in our case, the ONM funds doesn't sit with the institution where the water system is being installed. If they, for example, in some part of Kenya, we work with the self-help groups. Those self-help groups, they have the income collection system. They keep that money to supplement to the ONM cost. But where we don't have such system, money sits with our partners. They are the ones who are responsible for buying part, and they have cars, they have all the equipment that is needed for operation and maintenance. So this is our particular experience. The money doesn't sit with the clinic or schools in any way. It sits with the partners.
But in some cases, thinking maybe in some cases there are also some partners who give funds to the Ministry of Health, so that the Ministry of Health then, sends that money to the facility level for them to manage that happens especially with funding organizations. But you're right, like us also, we have this ONM fund where we are seeing the implementation where UNICEF is the one resources, but I know that in some cases where you have organizations that provide funds, they will give us money and say this is for this, that, this amount for ONM, and the ministry is responsible for making sure that the money reaches the facility level so that they can provide the water and also maintain those services. I think it depends on the organization. But also maybe to ask administration about who is the question of the costing and information. At organization level, if you're working within this organization, it's the program of the people who are implementing the programs, But that's one costing, you're costing within the organization. But there's also the costing for the sector, which I think that's one of the ways. I don't know if this is what police representing earlier. So if you're posting for the sector, sometimes you are need to liaise with the different sectors, with the government, but also NGOs in the country. And I think that's where you encounter this challenge of getting the information. Some organizations will hold it. They will not want to share, yeah? Yeah, others might want to give you. So that information becomes sector information because that's the posting exercise or tool or information for the sector to help them to plan for provision of these services in healthcare facilities.
I hate to interrupt, but it's a great discussion. But when we have just 7 minutes, everyone do compliment teachers. I would like to do a report on not repeat. As a group, summarize a few key points that we would like to share out with the other group. You can read my handwriting, but
I think eventually.
So I think we feel like
holding costs
all of the questions, yeah, we've touched on them, right? You did a good job answering those. Yeah, the strategies are
So nobody has done that. There are ways that I don't know how advanced the insurance
current approaches to costing, a lot of good information and effort being done up front in terms of construction,
It says healthcare with insurance.
more uncertainty when it comes to the long-term O&M.
So when you're looking at how you do the WaSH and healthcare facilities.
And that kind of touches on the second one as well, and that cost data, really big use of that upfront space.
Sorry.
I think you can ask about
I think we can start off.
barriers to that.
Well, I think that's a kind of a good place to end on.
So there is that uncertainty around population growth, inflation,
Any final burning thoughts?
how the system will be used and maintained, other barriers that I should mention that I didn't capture that were discussed.
Is that helpful? My experience with that, with having a personal voice and narrative, incredibly helpful.
The intended audience and maybe reluctance to be transparent about what is being spent. Great.
Did a survey with
Strategies to overcome there. We
originally
didn't end on success stories. Does anyone have any success stories that you want to highlight out for the group?
We have a call to donors, please fund like longer term, consider like stop, go with 1-year projects and kind of think of long term these organizations, institutions, and others. That's just like the.
I guess we have several mentioned funding, long-term funding from revenue generation.
Now they have
Can you raise that as a success story maybe? As one
Yeah,
strategy?
the self-help group. So it works like, I don't know, people in microfinance, village banking. So people save, they save money. In some cases, that money get used to purchase something which they will sell in return and get profit from that, and they continue saving, and they have in doses. It's not really, sometimes, especially with the new technology, it's not a significant amount of money which you would say it will really cover the entirety of O&M for that particular, but it's a step in the right direction in a sense that people are being mindful, and this system breaks. We have to make provision for those breakdowns when and if it happens. So those village banking savings model can be a strategy
Our other group seems like they're ready to discuss. So I'm going to transition us back to the whole group so that we can hear what the other group has to
I think I am.
Great, I will support that voluntarily.
Great, thanks everyone. If I can reconvene the group here, I want to be respectful of the fact that people may have meetings after this. So thank you so much, everyone, for coming to this session. It was great to hear from our presenters. It was great to hear from so many of you all in the audience that have such deep expertise on this topic. We're really grateful to hear your experiences and to have you share your knowledge with us today. So we'll do a quick report out just so that each side can hear what the other side said. Lucy, why don't you start and then I'll close the session.
Great, thank you everyone. So we had a great discussion. We had a nice mix, I think, of people from the NGO world, the government world, the research world to kind of share how different of folks use and apply cost data as well as generate cost data. So if you'll go back to refresh memory. So we found that people use cost data for prioritization as well as a lot of talk about how cost data can be used for advocacy. So understanding what the needs are for WaSH and healthcare facilities and being able to really communicate clearly to government at the local or national level about here are the needs, here are the gaps, and here's a very concrete, specific plan of how we can address these needs with investment. We talked a lot about ways to kind of use data for advocacy and different types of data that can be used, the importance of tailoring your data to the stakeholders. So for some people, they might be interested in kind of the cold hard data on costs and budgets. Others might be interested more in personal stories or in data on the impacts of WaSH. And so considering how you can kind of build this narrative to help advocate for funds. And let's see. And then in terms of kind of overcoming barriers to costing, we talked a lot about collaboration, both within government, so looking at how WaSH is funded across different sectors and how you might need collaboration between different ministries to support WaSH funding in healthcare facilities, as well as among government and NGOs. So thinking about how different partners can kind of bring something different to the table, and it's important to consider how different people can fund different parts of a costed roadmap to end up with kind of a fully funded WaSH in healthcare facilities. So I think that was the main points, but if anyone else from our group has anything else to share, feel free. Yeah, okay,
Great. Really pleased to hear that you all touched on more of the policy and advocacy side of things, because this side of the room focused much more on programmatic and practice applications of data. So I'll reflect back on the 4 questions that are on the screen there. In terms of current approaches used for costing, most of the folks in our group were talking about costing upfront. So having local suppliers that knew the costs of installing systems, having national price lists or organizational price lists for what was acceptable to charge or what the given cost of a particular input, for example, to build a system would be. But then much less being known about the ongoing operations and maintenance costs, particularly as those systems age 5, 10, 20 years into the future, things become much more uncertain. So stakeholders mostly applying data on the front end and kind of decreasingly applying data on the back end. Some of the biggest barriers to that people mentioned being uncertainty about the future, for example, how populations were going to grow, how the team was going to use a system, were they going to do recommended maintenance, or was it the system going to be used hard and then burn out after 10 years. Also barriers around sensitivity of data, kind of unwillingness to share it, perhaps to sensitivities around who's making a profit and wanting to kind of protect that information for business or other reasons. And then we'll end on a success story here in terms of a few great examples of revenue generation at the facility, some discussion around microfinance and communities being able to raise money for long-term operations and maintenance, even where project budgets had run out. Anything to add from my group here? I'm getting a few thumbs up. Okay, great. We'll close the session there. Again, thank you so much for joining us. We're moving into a 30-minute networking break, and then verbal presentations will start again at 3:30. Thanks, everyone.